are not necessarily those of the staff and management of Salem Media of Hawaii.
Aloha, everyone. Thank you so much for joining me today on Be Fit for Health Radio. This is Bianca, your host, and it's another wonderful Sunday. Just wanted to reach out to everybody and thank them for so much for tuning in for the past couple months here. The show has been around now for about 4 months, and I'm so grateful and honored to be here to be able to bring you the latest information when it comes to your health and well-being. And I've had some incredible guests come on my show, and it's been such an education for me and a confirmation as well for some of the things that I thought about when it comes to my own health. And, you know, the whole premise of the show, again, is for us to learn together, to get an idea of what we can do to, you know, best suit our lifestyle so that we can live a healthier quality life. And to do that, we need to learn. We need to get educated and, you know, and to understand what's causing our downfall or maybe hiccups that we may be having in our day-to-day lives. So, you know, today is no exception. You know, I've been very lucky every single week in bringing in such intelligent, informative individuals that are in the medical community or in the wellness community, trainers, nutritionists, things like that. And today I actually went ahead as far as reaching out to someone all the way in New York City. And he is a medical doctor, but he's a general surgeon on top of that. And he's been working in the front lines, you know, for the past couple months now with this COVID-19 thing. And, you know, the whole premise of this show is for me to try to get some idea of what's really going on out there. What it's been like for him as a surgeon, you know, what some of the things that he's been dealing with some of his patients. You know, his background is pretty extensive. You know, he's got his BS degree in biology, his MS in physiology, and in biophysics. Gosh, you know, I love physics, but I'm sure biophysics sounds really hard. But he's also got his MD at Ross University, a School of Medicine, and he's been practicing his residency right now for the past few years now at Barnabas Hospital. And it's been quite an interesting journey for him. And some of the things that he talked to me about previously to this show, you know, all the things that he had to go through to become a doctor. And we're going to learn all about that because we really don't know what doctors go through, do we? You know, on their journey to becoming a doctor and what it's like for them to treat their patients. So we're going to get a chance to find all that out. And his name is Michael Jamgochian. You guys thought my last name was hard. He's laughing. You guys can hear him giggling. Michael, are you there?
Yeah, I'm here.
Oh.
Yeah, it's the last name.
I know. You know, it's, you know, living in Hawaii, you don't know this because Hawaii's got some really long names, and you got all these vowels and consonants together. And then, you know, when we have tourists coming here and then they see all these signs, you know, Kamehameha, you know, they're like, how do you, or, you know, Waikiki is easy, but then people pronounce it Waikaikai, or we have a highway that's like Liki, but they call it Likey because it's spelled L-I-K-E. It's so funny because, you know, they try to pronunciate it, but it's so off. And then here's our last name. And we fit perfectly into the Hawaiian culture. So welcome to Hawaii via, you know, this interview. I know you had a long night because you were at the hospital on call for 24 hours. So I hope you got some rest today.
Yeah, I did get a little bit of sleep. That was good.
A little bit of sleep. That's probably like 1 hour, people. You poor thing. Well, I appreciate. Yeah, I know, and I appreciate you being on here because I know you're busy, and I know that you deal with a lot when you're, you know, in the hospital. So I know that there's a lot of stuff that's going on out there when it comes to, you know, the viewpoint right now is, and the focus is on hospitals and the way that they're trying to take care of a lot of patients that are so outside of what you normally would be dealing with, on top of, you know, the regular surgeries that you would be performing. I know that the COVID has put a little bit of a different norm for you guys. What has it been like at your particular hospital dealing with this new way of dealing with patients with COVID-19?
Yeah, the COVID virus kind of changed everything really, but for surgery specifically, all these elective cases that we would have had scheduled and had patients come and do routine surgeries like hernia repairs, for example, um, any kind of elective procedure that's not an urgency or an emergency, uh, we would have them scheduled and come in and do surgery. But because of the whole COVID thing, all of that kind of got put on hold. It's actually starting to pick up now in a couple different hospitals. So it is getting a little better. But during the whole COVID thing, all these cases were canceled. So we had really not much to do, as a general surgery service, aside from traumas. We did have patients coming in as traumas or as emergencies, appendicitis, things like that we had to deal with. Those cases were still going, and we were still doing surgeries for those people because they were deemed emergencies.
Right.
But aside from that, we really didn't have much to do. So then what ended up happening was, because as the hospital got overwhelmed, the medicine service and a lot of the other doctors in the hospital, they were completely overwhelmed with the amount of cases and patients that they were managing and dealing with. So, as another service in the hospital, we took over some of those patients. So, patients that are in the intensive care unit, we're used to dealing with patients in the ICU because we have our own surgical ICU.
Right.
So what ended up happening was all of those patients that were really, really sick, we just turned our surgical ICU into a COVID unit, and that's kind of what happened throughout the entire hospital as well. Even regular floors where nurses are taking care of medical surgical patients on the floor who are not necessarily ICU trained, all those floors got converted to COVID floors. So we had all these very, very sick patients, and we were managing them, and we were helping out, and we were doing our part as far as the management of those patients. And we were coming into direct contact with very, very sick people. So it was
Did
it
you
was
guys have
definitely an experience.
Did you guys have
And
enough protective gear though, Mike? I mean, did you have enough of the face masks or the guards that you were talking about, or the suits? Because in the media,
yeah,
they made it so that it sounded like you guys were without the stuff. I mean, is that true for overall in New York? I mean, I know you work only in a few hospitals, but is from what your other colleagues may have said, was it true that they didn't have enough gear to protect the employees that were working at the hospital?
yeah. I mean, as far as I noticed, from the couple hospitals that I work at, we actually weren't in a shortage of PPE, but it was carefully distributed. So, in other words, if you have a box of face shields and N95 masks, typically you would go in and out of a room and you would wear a mask and you would throw it in the garbage. But because we knew that we would be going in and out of the rooms, there were so many patients, there's only so much PPE. So what we would end up doing was, we would probably wear the same mask for a few days or a week even, just to kind of limit the waste and, the abuse of the PPE. So,
What
but
exactly
we
is a
didn't,
PPE, Mike?
we didn't actually, PPE, personal protective
Got
equipment.
it.
So basically what that means is, when you're going into a room to take care of a COVID patient or even any patient who's not COVID, who contact precaution or they have a really bad and resistant bacteria infection, we would have to wear some protective equipment to go and take care of them. So examples of that would be uh, full body gowns, face masks with a shield, N95 masks if it's an airborne disease, gloves. All those things that we use on a day-to-day basis. We have to be really careful of how we're using them. You don't if you're going to go into a patient's room, you try to do everything you need to do at that one time. So before you would go into a patient's room, let's say, oh, let's do the blood, and then you leave the room, and it's like, oh, okay, now we have to get a sputum culture. So if you're going into the room, you have to keep in the back of your mind, like, okay, these are all the things I need to do for the patient. I need to examine the patient. I need to draw blood. Like
Wow.
all those things need to be done kind of at the same time. So we kind of had to strategize, when we're going to see patients, how we're using the PPE and the amount of times we go in and out of the room, just to kind of not waste it and not go into a shortage.
Right.
But we definitely didn't have a shortage. We definitely did have enough to go around. It was just monitored and regulated.
So the next question would be then, were the hospitals saturated as much as they said that it was? Because you guys were like the lead in the United States when it came to the most COVID cases and the most deaths and things like that. So was it as saturated as the media had made it out to be?
Yeah, yeah, if you just look at the population of New York City itself, it's very densely populated, especially around Manhattan. And where I'm in the Bronx, it's very saturated with just people. So our hospital, it was so saturated to the point where, as I was saying before, all these floors that are typically not even able to handle certain levels of care, they were all turned into COVID units. So like endoscopy suites, regular med surg floors, everything was just converted to a COVID unit. And then the emergency department too, it was separated. There was like a COVID section, non-COVID section. But if you looked at all the rooms, like a typical ICU room is only supposed to have one patient per room.
Yeah.
And during this whole COVID thing, we had two patients per room, and the nurses who were only supposed to handle maybe one or two patients per nurse, they were dealing with 4 or 5 patients,
Oh.
all with COVID, all very ill. It's very difficult to take care of that many people who are all very sick and all have a lot of needs all at the same time. But our staff was up to the challenge, and we did it, and we had to kind of adjust.
But were these patients all just COVID, or were these like COVID made whatever circumstance they were dealing with beforehand worse? Like, asthma patients or heart patients, but they had to come back in because they got like flu-like symptoms, which made their body, not be able to combat it as, let's say, someone who's a bit healthier. Like, I'm trying to debunk some of these myths, but at the same time, some of the things that we watched on the news, because one type of station may say one thing, and then another station that's maybe more conservative or what have you may say another thing. I'm just curious because you're there, just like I'm here in Hawaii. I know what's going on in Hawaii, but you're there, so you see it, and you're one of those main people that dealt with the patients on a firsthand basis. So, as far as that concerned, was it all COVID strictly, or were these combination of illnesses that made these patients so sick?
Well, that's actually a very good question, and the best way to answer that would be to say basically the people that the patients that came to the hospital sick with COVID were the ones that had other medical issues, because most of the population, like normal, healthy people who don't have any medical issue, they don't take any medication, they're just walking around, very healthy and strong. Even if they did get COVID, they didn't really get too sick from it. They may have had like 1 to 2 weeks of a period where they kind of had like flu-like symptoms. They had altered taste, smell, malaise, like body aches, things like that. But those are not the people that came to the hospital. The people that came to the hospital were the ones that they couldn't breathe, and they had to call 911 because they were actually short of breath and starving for oxygen. So they called 911, and those people came to the hospital. And especially the ones that we took care of for all ICU patients, those were the really, really sick ones. And those were the ones that needed to have a ventilator just to have their lungs ventilate oxygen and get rid of carbon dioxide. The other patients that were not in the ICU and just on the regular floor, those were like the in between, where they were more sick than the average person, but not sick enough to the point where they needed to be on a ventilator. But yeah, I mean, the patients that ended up in the hospital, those were predominantly the patients that are sick to begin with. I mean, they probably have 2, 3, 4, even more medical issues underlying. And because of that, when they got the virus, their body is not able to cope with it, and their lungs were not able to get oxygen, not able to get rid of carbon dioxide. And when you look at their lungs on CAT scan imaging, I mean, their lungs look terrible. They look like Swiss
Fibrosis.
cheese.
Yeah.
like
So,
really bad.
so how
Those were the sick ones.
so how were you guys able to combat that? How were you able to take care of some of those patients? Was it some of the drugs that's out there now that, the one that was used for malaria? I forgot what that was called. I can't pronounce it, but
Hydroxychloroquine.
yeah, with zinc and some other supplementations. Did those types of medications help those patients?
There's still all these studies that are ongoing, looking at all these drugs and seeing the effectiveness and which ones actually work. Honestly, it's hard to say, but from my own personal experience, and we tried everything. I mean, we gave all the patients that came in who had COVID hydroxychloroquine. We gave them antibiotics. On top of that, they got azithromycin. Then we also gave them IL-6 inhibitor, interleukin-6. It's a inflammation marker.
Mm-hmm.
So they got that medication. Then we were running a trial of giving patients, it's called plasmapheresis. Basically, it's like if I took somebody who recovered from COVID, spun out their blood, and then filtered out the antibodies to COVID, and then gave that to another patient as a transfusion. That was another thing we were trying. And, we were doing all of these things, and some of the patients, they never got better, and a lot of patients expired. They, didn't make it, even using all those medications, even using the ventilator. Like, they were not able to recover from the virus, and they ended up, unfortunately losing their lives. Some patients did get better and did end up getting off the ventilator. But it was a long road for them, and they were in the hospital for a couple of weeks.
So my question would be too, what about injectable medications? Like, so I'm thinking with ventilators, there's I talked to a 60-year pulmonary doctor here in Hawaii, and he said ventilators aren't the best thing in the world because it can cause for some people blood clots and some other things like that too. But is there any type of an injection that people can get so that it can, like a high dose potent injection? Because sometimes when you take pills, it has to go through the process, right? It has to get filtered through the system.
Yeah.
But those injections that you guys give, I would think for some severe cases that it would be great because I'm not a doctor. I'm just thinking like a layman, like what would work and what wouldn't work.
Yeah.
And what were the age brackets of those people that expired? I mean, were they older? I mean, I'm not to put category sexism or ageism.
I mean, not necessarily. I mean, the older ones definitely didn't cope as well as the younger ones, but I mean, we still had patients in their 20s, 30s, and they were expiring as well. They were also losing their lives.
And what was that reason? Was it because they had underlying issues, or was it strictly
correct.
COVID?
Yeah, I mean, those, like, we would have somebody in their early 30s who was morbidly obese, and they have asthma, they have COPD.
Right.
They have diabetes.
Right.
There's just all these things that add up on the system,
right,
on the body system, and it's just not able to cope with the virus.
Right. And if they have poor diets, it doesn't help that either. Yeah.
Yeah. And then as far as the route of administration, as you were mentioning, like oral versus like IV, I mean, all of these experimental drugs that we were using, those were like heavy duty IV injections.
Right.
So, we were doing pretty much everything, and a lot of the things that we were doing were considered experimental because this is all brand new. Nobody's ever dealt with anything like this before. So, we were just trying everything that we could think of, kind of just, using a bazooka as opposed to, a handgun. Like, we're just covering all of our bases and using everything that we can think of to try to defeat the virus. And, unfortunately, even using everything sometimes didn't work.
Well,
And
ahead.
as far as the other part of the question with the ventilator,
Right.
it wasn't necessarily the ventilator itself that was killing patients. It's the fact that if you needed to get onto a ventilator in order to just get oxygen, like, you are already so sick to the point where, the chance of you recovering from the virus is so slim. And the ventilator itself, just gives gas exchange, but the mechanism of the delivery, we were using very high pressures to ventilate those lungs because they were so fibrosed from the virus. So, that was not really helping things either.
Can you ever
Just to
recover
give
from that?
oxygen.
Can you ever recover if your lungs become like that?
That's that's not really my area of expertise. I mean, that may be a better question for a pulmonologist.
Yeah.
But from my understanding, if your lungs are fibrosed,
Yeah.
that's probably something that's going to be
An
permanent.
issue. Yeah. That's sad. Because that's
Yeah.
like forever, yeah. And if you're a young person, oh my gosh. I mean, it's one thing if you're older, right? But it's like when you're a young person, you have that. How do you combat that for the rest of your life?
Yeah, exactly.
So, what do you think of the quality of this virus? Because I know you're saying, this is something we've never dealt with before, but then, this is part of the coronavirus family. This is like the new kid on the block. But it's like the way I'm looking at this virus, because I could be completely wrong, is that it's just, it's a weak virus, but it's a very fast moving virus. Is it because it's fast moving that you guys are feeling like we've never had to dealt with this before? Because we've dealt with stronger, more potent viruses before in our lifetime. So, what's making this virus so special to you, medical people? Like, what is it that's making you guys nervous about it?
Yeah, I mean, definitely the biggest concern is just the fact that it's so contagious. I mean, it spreads like wildfire. So, if people are not careful, you go to, let's say, wipe your nose, and then you didn't wash your hands, and then you went and touched something, and somebody else touches that, the chance of you transmitting the virus is very large. So it's such a quick and easy method of transmission, and aside from that, the virus itself is so it affects like every body system. Like, it's not even just your lungs; it affects everything. It makes you more prone to blood clotting, for example, is another thing that it does. So, it's just the fact that it's so easily transmitted and it can be very deadly for certain people makes it a very dangerous infection.
So, would you say that out of, and I'm putting you on the spot a lot because and I'm giving you questions that may not even pertain to your expertise or your area of information, but like, would you say that the number of deaths with this is higher than, let's say, the flu in 2018 when there was so many deaths according to that coronavirus? There was a lot of deaths in the United States. I think it was something like, I don't know, like 200,000 or something in 2018 for the entire United States. I mean, I don't know, in comparison to this, for a short amount of time, it's only been 6 months, I would say relatively, that we've been dealing with this, but I don't know. I mean, I'm just trying to figure this out because we're getting mandates from our politicians and our governments, and I'm just trying to make people understand the severity of this, as well as, with the cautions, as well as where is it becoming ridiculous. Do you know what I mean?
Yeah.
Where do we protect ourselves, and to what degree are we being told what's going on really? Because we have the right to be cautious, but we also have the right to figure out how we can deal with this, combat it, because we have our families and our older people here. We want to protect them. So what do you think? I mean, is it that that deadly compared to what we've dealt with in the past with other coronaviruses?
Yeah, I mean, I don't know the statistics and the percentages, offhand, but
Right.
from what I've noticed, it's very deadly, and it people are affected so heavily by the virus, even in the hospital. Like, we had a lot of patients die, and it was up to the point where I would come in for a shift,
Yeah.
and I think every shift that I went into the hospital, every single day for a good few weeks, there would be at least one person, if not one or two, during my shift that would expire.
Oh, wow.
And yeah, I mean, those pictures of refrigerator trucks, like those are real pictures. I mean, we had one in the back of our parking lot, and there was a giant
What?
refrigerator
Wow.
truck just because the morgue we're not able to handle it. I mean, they had never seen that many deaths before, so we had to put the body somewhere. And what they would do is they would call up a refrigerator truck, and they would, swing by, and it was terrible. But that's what they were dealing with. They were just like everybody was overwhelmed. Not even just the hospital; the morgues were overwhelmed, and
So would you say that
you
was
know,
because of the initial introduction to this virus to us? Would you say that it's the truth today with us being able to handle getting a grip on what this virus is like and what it's doing today versus what it was like in January or February or March? Would you say it's less deaths now?
yeah, it's definitely gotten better. We've slowed down dramatically as far as our case numbers have been. And our new admissions for COVID, the numbers have dropped like tremendously. Um, so all of those units that I was mentioning, like the endoscopy suite, the post anesthesia care unit, the floor, like all these places where we were putting COVID patients, they've all been converted back to their normal function. So
So that's good news.
definitely definitely the population in our hospital has come down significantly. And we've actually started doing elective cases again at a bunch of different hospitals now.
Right.
Um, so it is getting better. Definitely all the measures that we took in New York helped, mandating that people stay 6 feet from each other, people staying home, not going to like giant social gatherings. It was affecting everybody's quality of life. I mean, nobody could go to, you know,
Any
a
functions?
sports
Yeah.
function or a concert or anything. But at the same time, it did limit the spread of the virus. And that's, I think, the most important thing that we can get out of this is that, these things, these mandates, while they are, while they, excuse my French, but while they suck,
Yeah.
I mean, you have to do it because
Yeah.
otherwise the virus is going to spread. And people, you don't want to have a virus like this spreading so quickly because it can affect everybody's lives so drastically.
So my next question, because we're getting to a positive end of this conversation on COVID, because what you're saying
Yeah.
is great news because it seems like everything that we're doing, we finally got a grip on what this virus is. We're able to figure out how to treat patients better, to control the virus spreading, which is all good stuff. How effective do you think these masks are? One, that's the one part of the question. The second part is we just got a mandate not that long ago from the governor stating that we are not allowed to go anywhere without the mask per se, unless say in the gyms. How much
Mhm.
oxygen can you possibly get in wearing a mask when you're working out? I mean, can you get the right amount of oxygen as you train with this mask on your face, or is it better for someone to not have that mask when they train? Because especially if you're older, there's got to be
Oh, yeah,
restrictions.
that's a good question. So I mean, the mask definitely does not restrict oxygen going to your lungs. That's like a misconception.
Okay.
Um, for example, we would be, let's say, if we had a case that would have to go to the operating room. I would have to be in the operating room for like 2 to 4 hours doing a very difficult operation with not one but two masks and a face shield on top of that,
Oh, wow.
and and like a whole neck to foot body covering, like a gown.
Wow.
And even though the operating room is, kept on the cooler side, you're still sweating under that thing, and it's very hot, and you're standing the whole time, and you're, doing very, very fine, you're doing very fine motor movements, and you have to concentrate like throughout this entire time. So,
Right.
Operating is actually pretty physically taxing, although it might not necessarily seem it. Just by, if you just were an outsider and looking in, somebody standing there, like, okay, they're just standing there. But, you're actually getting a workout in there doing, operations. So you have not one, but two masks. We have to wear the N95. And then on top of that, we have to wear a second mask to prevent, contamination of the N95.
Wow.
So that one is keeping the N95 clean, and then on top of that, you have a face shield. So you have all these things on, and I mean, you're getting a workout in there. And I could tell you from personal experience, I mean, it might seem like you can't breathe, but you can get plenty of oxygen. And actually, even anesthesia would ventilate patients after they got extubated. So after they had the tube removed from the surgery, they would have a face mask on, and then they would put like a breathing cup, almost, I guess I would call it, over that mask, and have oxygen going through there. So the mask is pretty permeable to oxygen. So that's like, a common misconception that people say, like, oh, I can't breathe. Like, it might seem that way because you have something covering your
Right.
face and it's not comfortable, and it's, you might feel like you're being suffocated, but you're actually getting plenty of oxygen.
So what about when you're running though? If you're running and your heart rate's like going faster and you have to take in faster air in versus standing there. I know you're saying you had, that's one thing to have a lot of gear on you. Talk about claustrophobia. But then having like to run with a mask on your face, or exerting such heavy, stress energy by lifting heavy weights, and your heart's pounding,
Yeah.
and you need the oxygen to get in there to feed the muscle. There's no restrictions even there, you think?
No, because that mask, oxygen is a very small molecule, so the mask is pretty permeable to that.
Mm.
And actually, a good example I can give is even before this whole COVID thing happened, there would be people in the gym wearing. They have these like training masks.
Right.
I've never
A
actually
high
used one.
altitude type training type thing.
Yeah, it's I guess supposed to make it more difficult for them to breathe or something. I'm not exactly sure how it works because I've never used one in the gym, but I've seen people training with them, and they're doing some pretty strenuous exercises, and I've never seen anybody faint from that.
Well, the only concern that I have here in Hawaii is that, we have an older population, especially at the club that I direct at. And it's, you've got older people. They're complaining about having the mask on their face because they can't breathe.
Yeah.
It's kind of one of those things where you want to be honoring what your government officials are telling you to do and keep the mandate going. But at the same time, you also want to keep people healthy, and not, get into trouble. So I appreciate you clarifying that, because a lot of people are complaining about the fact that these masks are intrusive to their oxygen intake. So, it's important
Yeah.
for people to get that clarification coming from a medical doctor such as yourself working in an environment like that. So,
And actually, the other thing I would like to just mention as well. So the whole issue with these masks, because a lot of people were really freaking out about the fact that the mask has to be an N95, and people were like buying up all these N95 masks because they were scared, and they were being told that they would have to wear masks if they went out to public, like the grocery store or something. And everybody was thinking that they needed an N95 mask, and that's actually not true. So the N95, the only reason we wear it in the medical field is because, so the virus itself, it's not an airborne virus. What it is, it's a droplet virus.
mm,
But what can happen is when a patient, let's say, can't breathe and they need to go on a ventilator, and they need to put and we need to put a breathing tube in for them. When we go to intubate them, or extubate for that matter, the process of doing that, you can release droplets and they can become aerosolized. So think of, for example, like a Lysol spray. Like when you spray that, and if you were to look at the mist, that mist will hang around in the air for many minutes until it finally, settles out. So when it becomes aerosolized, it becomes almost like an airborne virus. So like an airborne virus would be like tuberculosis, for example.
Right.
So that is really the only reason to wear an N95 mask if you're going to be in that situation where you have to worry about having aerosolized COVID, because that can get transmitted. But if you are not in the healthcare setting and you're just outside, at the grocery store or any other situation that's not in the healthcare setting, you really don't need an N95 per se. You could just use any old regular face covering. A cloth face covering is adequate. And you just have to remember to wash your hands and maintain 6 feet apart and things like that.
Yeah, but the cloth won't protect you unless if someone sneezes on you, right? Because that cloth is not going to be as small.
Correct.
So it's not going to be as
that's
safe.
The reason for exactly. So that's the reason for staying like 6 feet away.
Right.
So if you're staying 6 feet away from somebody and you have that cloth mask, and you're right, it's not going to protect you if something gets aerosolized.
Right.
But that's the reason why you're supposed to stay far away from people, is if they do sneeze, God forbid, you don't want to be standing right next to them. But definitely you need to keep your distance. 6 feet away is plenty adequate. And especially if you're outside. If you're outdoors, that risk is even less, because now you're in the, general atmosphere. So, just maintain some distance from people, and, that's adequate, it's adequate personal protection.
Yeah, I agree. I think so. So last question before we go on a really quick, like 1 minute commercial break, is, so how long do you think this is going to stick around? Do you have an idea, a feel?
Oh, I wish I knew the answer to that question. Yeah, I'm not really too sure about that one. What I can say is that, at least from my experience in New York, we've been taking everything very, very slowly and doing it step by step. So, first they mandated, okay, nobody should leave their home, nobody should go out unless you need to go to the grocery store. Like, only very specific instances were you allowed to like go out and do things outside of your own home. And then after that, they said, okay, now, now it's safe to go to the barber. Okay, now it's safe to have a gathering of 10 or more. They're slowly implementing these steps to see what happens. Because if you just say all at once, okay, you guys can have a group gathering, 500 people, go for it, then you're just going to have a second wave of COVID. So I think the way that they've been doing it is very cautious, and it's very conservative, and I think that's correct. I would do the same way. And I guess the rate that it's been going, if I was to take a wild guess, I would say maybe by the fall, at least for New York. But now you have the other situation where it's not just New York, it's not just the United States, it's a global, thing. So, and now you have all these other states that have recently had spikes. So even though, New York is getting better, places like Florida, places like Texas, Arizona, they're having all these huge spikes. So, even though we're saying, okay, now we can do these things, you have to remember that people are still traveling from state to state. You can just get in your car and drive to Texas, and, you have all this cross exposure. So it's just that I think it's very important that everybody just kind of be careful, kind of tough it out. It'll pass eventually.
Yeah, like anything else, it's going to have its time, right? It's going to have its peaks and valleys. And from what I saw in the statistics, on the news, they were showing us numbers. We're doing a lot more testing in this country, a lot more. And yes, we're going to have a lot more people having the COVID-19. But the good news was that our death statistics was lower, and it's much lower here in the United States than it is elsewhere in other parts of the world. Even though we have the highest number of cases, we have the lowest number of percentage-wise, the lowest number of deaths in this country, which is kind of on the positive side in a way, I guess. But it doesn't mean that you're safe. I mean, you catch this, why would you take the risk, right? I mean, you don't want to be that one person that may expire because you weren't careful and you don't know what your underlying cause might be. Like you and I were talking, not everybody understands their body. You don't know what you're dealing with. You had mentioned somebody had diabetes and didn't know they had it because, they were living a certain lifestyle. This person catches COVID, they're going to pass away because they were that off balance with their health. So, but, it's so hard because I feel like we're just trying to figure this out day by day. I feel like no one has a solution.
Right, yeah.
No one knows what they're doing, really. I feel like we're kind of doing a hit and miss. Oh, this worked. Well, this didn't work, That's how I feel like our government's doing it here in Hawaii, even though we're lucked out. We've closed the tourists. They're not coming in yet. We did the same thing as New York. We stayed at home. We have spikes now. We're getting a lot more cases, but we're doing a lot more testing. We're at 0.019% of deaths here in Hawaii versus the cases of people infected. We have, I think, 1,400 plus maybe people who are infected here out of 100,000 tests that were done. So we're doing very well here in Hawaii, but that's because we're being very cautious. So we need to keep that up, Hawaii, so that we can stop this here.
Definitely.
Yeah.
Yeah.
Yeah. So we're going to, don't go anywhere, Mike and everybody. We're just going to do a really quick a break. And when we come back, we're going to talk more with Dr. Mike Jamgochian. And we're going to talk about all the things that are pertaining to him being a doctor and a surgeon. We'll be right back.
The Honolulu Club is still here for you. We are providing the safest workout conditions on the island. With modified safe
or follow on Instagram at Kelly's Time. Make your appointment today.
And we're back. And we've been talking with Dr. Michael Jamgochian. He's a general surgeon over in New York with a great insight on the COVID-19. We've just been talking about that for the past 40 minutes now. And it's been a very enlightening information, Doc. You've been giving us a lot of good insight as to what's been going on over there in New York. And I appreciate that because a lot of us who are trying to follow the news and trying to follow, our government officials and their mandates, some of us are feeling quite stifled, and some people are screaming it's our right not to wear the mask. It's our right to go wherever we want. There are reasons why our politicians are doing what they're doing. And first of all, too, and I want to say this to you because I know you well, you are a pillar of society. Thank you so much for taking care of us. Even though you're not here in Hawaii, you're taking care of the human race, and it takes a special type of person to become a doctor. And so for your kind heart and your need to serve, man, thank you so much for that, Mike.
Oh, you're welcome.
And the second part we only have like about 10 minutes left, and I'm trying to get everything in as much as I can. My show is like an hour long, but it goes by so quick. So I know you wanted to become a doctor, and I know I've looked into it briefly when I was younger, and it's really overwhelming the amount of classes you have to take and study. I mean, organic chemistry, biochemistry. You mastered in biophysics. What is that? Biophysics. What exactly does that mean? What do you study?
Oh, I did a 1-year master's degree at Stony Brook, and it was for physiology and biophysics. And basically, they were just extended courses from what I took at Fordham for the bachelor's. So it's it's just higher level biology and higher level biochemistry classes.
Wow.
I don't know if it's really a good way to explain that over a talk show, but basically it's those same courses just at an advanced level.
So so physiology is the study of like the nervous system, the way it works with the muscular system, the connective tissue and things like that, right?
Yeah, so physiology is just the study of the human body and all of the organ systems and how all of those function and how they're all interconnected and how they work together and um, all those things.
And that helps you in surgery. How?
So yeah, that's actually a very good question. So
I have my moments.
I think one of the things being a surgeon is that you have to basically know about everything. So medical school basically just trains you to be a doctor, a medical doctor. So you understand anatomy, you understand physiology, you understand pharmacology, the study of the drugs and how they
Right.
work on the body, how the body works on the drugs. Um, Basically everything about the human body, right? So you go to medical school, you do all of that, and then you come out of medical school with your MD degree, and you have learned all these things, and now you're ready to go into the real world and actually, be a doctor. But before you can be a doctor, you have to have some sort of actual training in the real world because in medical school, you do 2 years in the classroom, and then you do 2 years, kind of as a student in the hospital, you're kind of shadowing, you're doing clinical experience.
Hmm.
But you're really not acting as a doctor because you can't prescribe anything. You don't have that MD degree, so you can't prescribe medications. You can't, do a lot of the things that doctors do on a day-to-day basis. So you're kind of just like shadowing and you're following,
Right. It's like your
the
training.
residents and the doctors around.
Yeah.
Exactly. So then after medical school, now you're ready for the real world. Now you're ready to actually be a doctor, but you have zero experience, right? So
Right.
what ends up happening is you do a residency. So you could do family medicine, you could do internal medicine, you can do psychiatry. Like there's all these little specialties that you could go into. So I decided to go into general surgery just because, I really enjoy working with my hands, and general surgery is a very hands-on way to practice medicine. And I think the coolest thing about it is you can actually just manipulate living tissue and manipulate organs to cure disease. I think that's so fascinating.
Wow.
And the other thing about being a surgeon is you have to know radiology, you have to know internal medicine, you have to know pediatric medicine. You basically have to know everything
Wow.
about everything because when you're going to take a patient to the operating room and they have appendicitis, let's say, you have the radiologist who's reading the images, but at the same time you have to also look at the images yourself.
Right. To know where you're going.
Exactly, and to see okay, where's the appendix? When you look at the radiology read in the comments section, it's just going to say, patient has appendicitis, and the appendix might be 1 centimeter in diameter. But they're not going to say specifically, okay, the appendix is here. So when you go to look at the CAT scan, the appendix can be in a whole bunch of different areas. So if you're the surgeon and you're going in to operate on somebody, you kind of want to know where that appendix is. So you have to be able to look at all those pictures yourself. And,
Right.
Part of our training is we get to learn all these things. So that's really what I love about general surgery is that you have to know all of these things and prepare yourself to be responsible for having a patient in the operating room under general anesthesia, and you're operating on them. You're cutting them open. Basically, it's like scary.
I would assume so, because when you open up a patient, it doesn't look like in the pictures, does it? Like it's all, you got all this mush, in there. So you have to figure out what mush is from what mush,
Yeah, it doesn't look like the textbook, and not every patient reads the textbook either, as they say. That's like an inside joke with surgeons. If the patient doesn't read the textbook, it means that they have something that's out of the ordinary.
Yeah.
But yeah, as you said, the textbook has nice little pictures and everything is where it's supposed to be, but you go to operate on somebody and not everything is where it's supposed to be.
Right.
So I guess getting back to the main question, with general surgery, I just think it's fascinating, and I think it's really rewarding to know that a patient can trust you enough to take them to the operating room and you
cut them up.
Do some surgical procedure, cut them up, and then your main goal is to heal them, and obviously not do any damage.
Right.
And the part of the oath of being a doctor is do no harm. Well, there's really no greater harm than cutting somebody open. So it's kind of like ironic that you're harming the patient, but then you're fixing the patient.
Because there's always a chance of infection whenever you cut somebody. I've never had any surgery, knock on wood, on me. I'm lived a pretty decent amount of time, and I feel like I've been blessed not to be under any type of knife. But not everybody can say that, not even for a knee or nothing, and nothing minor, maybe my teeth, but that's about it. But I would say it can be dangerous. You're opening yourself up to possible different types of bacterias, and surgery is not always a good guarantee. But, for you, I was going to ask you, what was the toughest surgery you ever had to do? What was the procedure?
It's such a difficult question to answer because
everything's difficult.
Everything is, I mean, obviously some things are more difficult than others, but I think the main takeaway point that I would like to drive home with that question is that there's no such thing as a routine surgery. So, somebody has appendicitis and you go to take out their appendix, most of the population would say, oh, that's just a routine operation. They're just getting their appendix out. No big deal. Well, guess what? Those appendixes, you go to take out the appendix and that could turn into a nightmare. I've seen really, really bad cases of appendicitis where, we couldn't do it laparoscopically and we had to actually make a very big incision to get the appendix out. And sometimes you actually have to remove a part of the colon to do it.
Right.
So, there's no such thing as a routine operation. You really don't know. Well, I guess a good quote from Forrest Gump, it's like a box of chocolates. You don't know which one you're going to get. But
you just quoted Forrest Gump. I can't believe it.
Yeah, I mean, it's true because you really don't know what's going to happen.
Right.
You could go in thinking it's going to be the simplest thing in the world, and then you go in there and you're looking at something that you've never seen before. So, it's just, there's no such thing as a routine operation.
Well, I give you guys a lot of credit. You guys do a lot of hard work, and being a surgeon of any type is a challenge because, like you said, you don't know what you're going to get when you open somebody up. It looks great in the imaging, it looks good in the MRI, it looks good in the photos, right? The person may look healthy as well, but you open them up, they're a mess, and you have to figure out where you need to go first to fix it. So I think I'm with you. And I know that my brother too was looking into being a doctor. We both like surgery, the idea of it. Who knows if we would have been good or not, but at least, it was an option back then, was maybe different times, but today is a different world. And, I think, I just want to say thanks again for doing what you're doing. Without doctors like you, a lot of us would be in a lot of trouble. So we need more doctors. I think we have a shortage in this country. I think we need more doctors. But I know it's been difficult through a lot of the, red tape that they have to go through. I know you guys have to do a lot of administrative work too on top of your surgeries. So, but we ran out of time, Mike. And maybe when this thing gets a little bit less crazy, or if it gets really crazy, I'll bring you back on just to have my New York connection, and we can discuss what's really happening out there. I appreciate you educating the people of Hawaii. You are now a famous doctor from New York to the Hawaii people. They'll know you. They'll know you as the other funky name, Jamgochian. I'll keep saying your name so people get to familiar themselves with you. You'll be famous here in Hawaii when you get here. So, but I just want to say thank you so much. It's been a pleasure interviewing you, and I appreciate everything you do. Give my best to everybody that I know in New York, and we'll talk to you soon.
Okay, that sounds great.
Take care.
You, Bianca.
Okay, no problem. All right, everyone. Thank you for joining me today. We'll see you next time. Take care of yourself. Stay healthy. Be safe. And aloha.